broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and thank you for joining today's webinar, How ACOs Can Ace Bundled Payments. We will be giving an overview of the Bundled Payments for Care Initiative, Advanced, which is CMS's latest voluntary bundled payments model. We will also share success criteria for ACOs based on our experience implementing BPCI-A. Then we'll review the timeline, which, as you know, is quite short, and the process, and introduce you to how Persivia can help you in your journey. Before we begin our presentation, there are a couple things I would like to bring to your attention. If you have any questions during the presentation, please type them into the question box on your GoToWebinar control panel. We will leave time for Q&A after the presentation, and we will be providing all attendees with a link to the webinar recording after today's event. Our presenter is Dr. Mansoor Khan, who is Chief Executive Officer of Persivia. Dr. Khan has decades of experience leading organizations providing healthcare information technology to improve both the quality and the cost effectiveness of care. He is actively involved in counseling Persivia's customers and how to succeed with bundled payment programs and other value-based care contracts. Dr. Khan, please go right ahead.
Thank you, Amy. And good afternoon, everybody. Thank you for taking the time to join us here. We expect the presentation will take about 30 minutes or so, and then plus any question and answer period, which will be as long as it needs to be. I'd like to start just by taking 1 minute to talk about Persivia, and then we'll get right into the bundled payment models themselves. So Persivia is a company that serves about 250 hospitals nationwide. In addition to that, we serve about 4,500 ambulatory physicians. In the BPCI program, we currently serve 34 hospitals covering over $750 million in overall spend. Overall, we touch about 20 million patients and 60 million encounters. We have a SaaS platform and deep expertise in EHR integration and data acquisition. At a very high level, our products cover cost and utilization analytics, care management, care coordination, quality management, patient engagement, and telemedicine. And this platform is what we use to serve our customers and our partners in their needs and requirements for meeting both regulatory requirements and value-based care. So what are the bundled payment models? CMS has actually gone through a number of different models over the last almost 7 years now. And those models were models 1, 2, 3, and 4, and now we are in what is called the BPCI Advanced, or the Bundled Payment for Care Improvement Advanced model, which is an evolution of Model 2. What the original models were is not highly relevant, except for that it gives us some insight on how this whole process has evolved. So, for example, Model 1, it was the inpatient stay focused one on acute care hospitals, and the Medicare was paying the hospital the discount amount based on the IPPS. So it was a very straightforward model. Model 2 combined acute care and post-acute care, and then it looked at the actual expenditures versus a target price, reconciled those, and that's what would determine whether the participant made money or lost money in the process. Similarly, medical episode 3 was started with an acute care stay, but it was really focused on what happened in the post-acute environment. So it was focused around post-acute services, And then in Model 4, CMS makes a single prospective payment to the hospital for the episode and covers only the inpatient stay. So, and then the physician and other practitioners are paid by the hospital. So Model 2, the BPCI Advanced is an evolution of Model 2. And we are now in the second year of this, the BPCI Advanced model. The first year was 2018, with the first model year starting October 2018. And that is now well underway with, I think, a total of almost 1,300 episode initiators within that cohort. And we are now starting the second entry into this model, which is where the process will start in 2019, in April 2019, so literally any day now. And the actual model will begin, the first model year will begin January 1, 2020. CMS has recently announced that they may not have any additional opportunities to join this model after the January 1, 2020 model year. So if you are interested in this, there's actually a relatively limited time to make a decision and act on it. We expect that CMS will open the portal for application within the next week or so, and then there'll be about a 6-week period to make the initial application, and I'll talk more about that in a second. So let's talk a little bit more about the BPCI Advanced model itself. So it's a voluntary model. It's not mandatory. So you get to decide whether you want to participate or you don't want to participate. One key thing to understand is that this is an episode-based model, not a population-focused model like an ACO. So it's not like you have in an ACO you have a defined population that is attributed to your ACO, and those are the folks whose care you're going to be managing and whose care you're going to be judged against. In the case of a BPCI, it's based upon episodes. So let's say, and there are 29 inpatient episodes and 3 outpatient episodes. So one episode grouping is congestive heart failure. So if you have a patient, any patient that shows up at a participating facility with a admitting diagnosis of CHF would then be included within this within your BPCI population. So there is no defined population, but any patient that shows up with one of the DRGs or diagnoses that you have chosen to contract with CMS for, though they would count against you or count in your population. It's also a total cost of care model, which means that CMS is going to give you a target price for the episode that covers all of the acute and post-acute costs associated with that episode group or that set of DRGs. CMS will make a single retrospective bundled payment. The payment covers the duration of the entire episode, which is the anchor or inpatient anchor stay, plus anything that happens in the post-anchor 90-day period. And the CMS will provide preliminary target prices before the performance period for each model year. So you will know what your target price is before the year starts, and you can then start managing. If you have the correct tools, you can manage your processes and your care delivery processes accordingly. Hospitals or physician groups can join, and I'll talk about the various types of entities that exist within the model, but they can be either hospitals or PGPs. This qualifies as an advanced APM, so it meets that requirement under the MIPS. And of course, like everything else that CMS does, there is an element of this which is tied to the quality scores on specific quality measures that are identified in the BPCI program. So now for the sort of the nuts and bolts of the BPCI program. So there are 3 types of entities that are defined within the program: conveners, episode initiators, and participants. The convener is an entity that is the controlling entity. That is the entity that contracts with CMS to manage the program, and that is the entity that actually bears the risk, both the upside and downside risk of being in the program. Underneath the convener are episode initiators and participants. Episode initiators are the primary entities responsible for providing the care. So, and the conveners can be two types of conveners. They can be conveners that are also episode initiators, i.e. a convener that also provides care, meaning say a hospital that decides that they want to be in this program and be a convener, carry the risk and also provide the care. Or conveners could be any other entity. You know, I personally could become a convener, theoretically speaking, and then develop relationships with hospitals and physician groups, etc., to be episode initiators under me, in which case I would bear the risk, but the care would be provided by the episode initiators, which would be either hospitals or physician groups. And the episode initiators are the primary entity for the financial gain sharing. The third type of entity are the participants. So these are all the other entities, physicians, SNFs, home care agencies, other hospitals, all the different entities that are involved in the care of the patient, but are not necessarily contractually bound to the convener. These entities may or may not be gain sharing partners. That decision is up to the convener. CMS gives the conveners a lot of leeway in designing the program, and the convener may or may not decide to share any of either the upside or the downside with the participants. Obviously, it makes a lot of sense to share it because then they have a stake in sort of ensuring that the right things happen at the right time, but there's no legal requirement for that. So just to sort of re-emphasize this, conveners can be acute care hospitals, physician groups, or other entities. Conveners can be both just independent conveners, or they can be episode initiators. But episode initiators, only acute care hospitals and physician groups can be episode initiators. So an episode initiator can be a convener, but a convener as of themselves, cannot necessarily be an episode initiator unless they happen to be either a hospital or a physician group. And then there are participants, which is all the other entities that may or may not carry any risk, but that are involved in providing the care, and that may or may not have a contractual relationship with either the convener or the episode initiator as far as the BPCI program goes. So what is a clinical episode? So a clinical episode is a process that begins at the start of either an inpatient admission to an acute care hospital, the anchor stay, or at the start of an outpatient procedure, the anchored procedure for those episode groups that are outpatient. So there are three outpatient procedures and 29 inpatient procedures, and the initiation of any of those starts the episode going. The episode lasts for up to 90 days after the anchor end date. What that means is that all of the costs associated with the care of that patient for 90 days after the anchor stay ends are attributed to that episode and attributed to the episode initiator. On a semi-annual basis, so twice a year, CMS will do reconciliation. They will take all of the aggregate fee-for-service expenditures for the episodes that are attributed to any given episode initiator, and then they will compare that against the target price for that clinical episode. And remember, the target price is provided to the episode initiator before the beginning of the year. And then based upon whether that difference is positive or negative, the CMS will determine whether that episode initiator is eligible to, or that convener actually is eligible to receive a payment from CMS, or is required to pay back CMS, whatever that loss was. So one thing, the other thing to keep in mind is that the convener is the entity that bears the risk. But the convener also has the ability, if they have multiple episode initiators under them, to average out the risk and the positive and negative amounts across all of those episode initiators. So if one episode initiator makes money, another one loses money, the convener could theoretically, break even if those amounts happen to be the same. Here's a listing of the episode groups that are defined for the BPCI advanced program. I won't spend much time on it, but you can see that there is quite a few, and there's a significant focus on cardiac and surgery. So one of the questions that arises is that if once an admission occurs, which entity will get that episode? If there's only one entity in any given geography that patient could be that is an episode initiator, then of course that entity will get that episode. But suppose that there is, there's a physician group that is in the BPCI program, and there is an acute care hospital in that same area that is in the program. So, and they're both, contracted with CMS for the same or overlapping episode groups. So suppose they're both selected the CHF and the pneumonia episode groups that they're going to be responsible for. So then the question becomes, if a patient is admitted with with a diagnosis, admitting diagnosis of CHF, does that episode go to the hospital or to the physician group? So in general, the physician group wins out over the hospital. So the first priority goes to the PGP that submits a claim that includes an NPI for the attending physician for that inpatient stay. The second priority after that is that the PGP submits a claim that includes the NPI of the operating physician. And if neither of those is there, then the acute care hospital will get that episode. So physician groups tend to have an advantage over hospitals in this in the BPCI program. So how does the whole program work? So at a very, very high level, you can think of this whole program being divided into two phases. Phase one will begin sometime in the next few days. CMS hasn't yet announced a date, but they have announced that it'll begin in April. So, and it'll go through the end of December. And in that phase, the entities that are interested in becoming conveners can file an application, select the episodes, and there are other things such as selecting episode initiators, etc. Various contracting issues are resolved. So all of that happens in phase one, which will start in the next few days and end prior to the end of December 2019. On January 1, 2020, the actual program starts, and from that point onward, each episode initiator will be responsible for managing the care, coordinating the care, and eventually being involved in the gain sharing that results from the program and from the care that's provided to the whichever number of episodes are associated with that episode initiator. So there is an initial application and setup stage, and then there is the execution and operational stage, which begins on January 1, 2020. So how does the episode selection work, which is actually a critical piece of this whole process? So the way the process works is that the CMS will open the portal for applications, and you basically have to file a preliminary application, sort of equivalent to the notice of intent that one files for when one wants to be an ACO. CMS will review that, and if they determine, and if they accept it, and they determine that the entity is appropriately qualified and has the required resources, they will then release to them claims data, 3 years of historical data for all of the potential episode initiators that entity has identified in that initial application. And that data is adjusted for case mix, for geography, for inflation, etc. So for the 2018 program year, CMS provided data from 2014, 2015, and 2016. So our assumption is that we'll get data for 2015, 16, and 17. And the data covers all of the claims for inpatient, Part B, outpatient, SNF, durable medical equipment, hospice, and home health. So it's a pretty extensive set of data that CMS provides. And the intent of this is to allow each applicant to review their historical costs and compare that to the preliminary target prices that CMS also provides them, to then figure out which episodes they wish to or they would like to contract with CMS for. And so you start to see why this program is such a good idea now, because before you enter the program, you get to see where you can potentially have positive gain sharing and where you might potentially have negative gain sharing. So what happens is that the data comes in. If you were working, for example, with us, you would give the data to us. We would analyze the data, and we would then produce charts like the ones you're looking at over here. What this chart shows is on the horizontal axis, it shows the number of episodes. On the vertical axis, it shows post-anchor spend. So if you're high on that in this chart, high on the left vertical axis, you have more post-anchor spend and less inpatient spend, or less anchor spend. And if you're to the right, you have a lot of episodes. Each circle is one of the episode groups, and they're color coded. So if they're green, that means that the target price is higher than the than the historical spend that CMS provided in the in the data that that they provided for the evaluation period. And the size of the circle tells you kind of how positive that is. So what you want to do is you want to select those episode groups that are sort of in the top right-hand quadrant. So they have a lot of episodes, which means there's good volume there. And because they are high up, there's more post-acute spend, so there's more opportunity for controlling spend, because that's some of the easiest spend to control. So green circles in the top right-hand corner show you that basically, as long as you keep doing what you have done historically, i.e. your performance hasn't significantly degraded, you are pretty much guaranteed to come out with positive gain sharing. So in the case of this episode initiator, our recommendation was that they select AMI, CHF, renal failure, simple pneumonia, and unitary UTI infections as the episodes that they contract for. The other part that should happen, and that's a very important part of this first phase, is the structuring of the gain sharing model. So the gain sharing model is based upon a savings pool, which is basically the target price minus the spend. And the spend has, this saving pool has two components to it. There's the anchor component and the post-anchor component. The anchor component is related to the savings that result from the anchor stay or the anchor procedure, and the post-anchor, of course, results from all of the expenses that occur outside of the post the anchor event, the anchor stay or the anchor procedure. And the result could be either positive or negative, and it's capped at 20%. So it can be up to 20% positive or down to 20% negative. If it's positive, then CMS pays the episode initiator. Well, technically they pay the convener, but eventually it works down to the episode initiator. And if it's negative, then the episode initiator pays CMS. CMS, as I mentioned, has given a lot of leeway to episode initiators in how they construct their gain sharing agreements. So they have a lot of leeway in how this constructed, but they have to have a gain sharing model and a gain sharing agreement. So whatever it is, it needs to be transparent, and it needs to be clear to any participant what, if anything, they will get based upon the performance of the entire entity and on their own performance. One cap that CMS has put in is that participants cannot be paid more than 50% of their fee-for-service billing. So if, for example, a physician billed $5,000 for that episode, the most they can get in gain sharing would be $2,500. Because keep in mind that the gain sharing that comes from the saving pool may have resulted from other the cost reductions in other areas, not necessarily related to that physician's $5,000 of billing. So if the SNF stays, for example, were excessive, and the program managers and the care coordinators managed to reduce those significantly and generate $100,000 in savings, that doesn't mean that goes to the provider. The providers are limited, and all participants are limited to 50%, up to 50% of their fee-for-service billing. There's also a quality component to it. So CMS will hold back 10% of any positive reimbursement amount until the final quality scores are available at the end of the year, and then based upon the quality score, they will make an additional payment, which could go anywhere from 0 to 20%. So theoretically, the NEPRA, or the net positive reimbursement amount, can vary from the 100% that you calculate from the saving pools by plus or minus 10%. So you might actually receive anywhere from 90 to 110%. Here's a list of the quality measures. The way these quality measures work is that all of them are claims-based measures, and CMS will calculate these. So there's no reporting, etc., that has to be done for the quality measure. CMS will calculate these based upon the data that they're already getting, and based upon that, they will calculate a clinical quality score for all across whichever measures apply, and then use that to make the adjustments to the final payments. The key thrust of the BPCI program is to reduce costs while maintaining or even hopefully improving the quality of care. And part of that is, or a big part of that is, care redesign. So CMS asks that all entities, all episode initiators and other participants that are in there would review sort of their whole care delivery process and redesign it so that they can provide, improved care, improved costs while maintaining or improving the quality of care. So key activities are: one, identify best practices, evidence-based best practices for the various episode groups. Take care coordination very seriously and implement care coordination procedures. So have care navigators, care coordinators that are reaching out to post-acute providers and making sure that they're in the loop, that they know what they need to know, and track patients across all of those environments. So so you know where your patient is, when they got there, when they're supposed to be discharged, and deploy the kinds of tools that you need to enable that. Reduce variation in care, right? That's a big part of BPCI, is to implement evidence-based care protocols and reduce the variation in care. To have available and activate continuous and timely decision support for all providers, preferably both anchor and post-anchor. And then, of course, monitor the performance to identify outliers, so then you can quickly react to those outliers, figure out what the issue is, and hopefully resolve those issues and remedy any problems. This is the 2018 timeline. It gives you a rough idea of sort of how things happened last year. We expect the timeline to be similar this year, except that instead of starting on January 9th, it'll start sometime, if CMS is true to their word, it'll start sometime between now and the end of April. And then it will go through the end of 2019 with the first cohort for this model year starting on January 1, 2020. So the process will be, a request for applications sometime in April. Shortly thereafter, the application portal opens and then closes roughly 6 to 8 weeks thereafter. CMS screens the applicants, and a couple of months after that period, the portal has closed, they provide data and target prices to the applicants. And within a month or so of that, they will distribute the participation agreements to each applicant. Signed participation agreements are due about a month later. And then the various other agreements and deliverables to CMS are due over the next month or so. Then CMS does the final announcement of the various participants, and the cohort starts, in this case, on 1/1/2020. So what could a BPCI implementation look like? So in the case of an ACO, you can think of the ACO corporate entity acts as the convener. So the entity that was formed to run the ACO can also become the convener. And it has some significant advantages in that process. That entity then chooses hospitals, practices, groups to participate as episode initiators under them. And they, in this first phase, the contracting phase, they select episode groups, usually episode groups that have either positive or negative or neutral payment, NEPRA, which is the net positive reimbursement amount. So basically start with those episode groups there where you're already in the money, so to speak. And then they have a gain sharing model in which they share the gains between the convener, the episode initiators, and at least some post-acute physicians and providers. So one typical model, that we've seen is the convener charges an administration fee of 5%. The episode initiators get 20% of any gain sharing. The physicians get 35% of any gain sharing, and the SNFs get, as a group, get 25%. So and any monies that are left over that because of the 50% fee for service cap, then go back up to the convener. So in addition to their fee, they get any excess NEPRA payments. So this is one model, but this is just a suggested model. There's no legal requirement that the model has to look like this. For example, a given convener could decide that they don't want to share any gains with the SNF, and make that zero, and then distribute that 25% however they wish among the remaining participants. So there's a lot of leeway that the CMS has provided. So success factors. What are the sort of things that you need to and should be doing to ensure success? So one is timely identification of patients that may be attributed to an episode group. So this is actually a pretty critical thing. So if you look out in the industry, you'll see that most tools available are claims-based tools. The problem with that is that, let's take the following scenario. A patient comes in and is admitted for CHF. They stay in the hospital for 8 days, so their anchor stay is 8 days. They get discharged from the hospital and go to a skilled nursing facility and spend 3 weeks there. And then they get discharged from there and go home. So you have now 4 weeks have passed, the patients have gone home, and CMS provides claims data monthly. So the best case is that at least some claims for that patient show up 30 days later, depending on the exact start date of that episode. By that time, and when your data goes in, takes about a week for it to be processed through your whatever analytics tool you're using. You get a report a day or two later. So maybe 40 days after the anchor episode, you get an alert saying that patient Mrs. Jones is a CHF patient and she falls in one of your episodes. Oops. So what do you do now? Not much. The patient's already gone through the whole process and is at home. So there's really nothing you can do for their care. And this process will be repeated every time. So having tools that can identify the potential patients that fit decision support and care management workflow tools, in addition to the claim-based tool that can identify patients at or very close to admission to let you know whether those patients fall or do not fall in one of your episodes is critical, because that allows you to then monitor that patient closely and intervene. And to do that, you need a single health record that's across, a longitudinal record for each patient that is accessible to all providers, acute and post-acute, regardless of the source EHR which generated the data. So you need some sort of an overlay system that allows you to take data from the different EHRs that are going to be involved, create a single record, and make that available to all of the stakeholders. The ability to take both claims and clinical data and convert it into clinically actionable information. So we want to take all of that information and use that not just to sort of look at cost and utilization, but also look at the care. Where is the patient? How long have they been there? Are there any gaps in their care? Are they appropriately medicated, procedures, so on and so forth. And all of that is going to be dependent highly upon having good decision support tools that are tailored to each episode group and for each set of episode initiators. And of course, finally, the ability to track patients across care settings from admission all the way to the home. So that's in the area of capabilities. In terms of processes, one of the key things is to appoint episode initiator level care coordinators or care navigators. So these are folks, and they don't have to be full-time at this job, but there should be somebody with this responsibility that is tracking the patient, that is watching patients that are being admitted, identifying those that are potentially potential participants in the episode, in any of the episodes, and then tracking them. And of course, creating relationships and having continuous communication with all of the different care providers, both especially in the post-acute environments. So that brings us to the sort of the beginning of the whole presentation, which is why should ACOs do this? So ACOs have some built-in advantages. First and foremost, they have the infrastructure to manage risk. So they've already invested in a lot of processes to track patients, to make sure that they have the ability to monitor and intervene if needed. So that gives them a big advantage right going out of the gate. Secondly, ACOs, if they are physician-led ACOs, then they will have precedence over hospital-led BPCI EIs or BPCI participants. So physician-led ACO episode initiators will have precedence and can basically take away episodes from hospitals. So that gives them significant volume. And of course, very importantly, at least in this round or so far, target prices have been generous. Will that continue in the future? We don't know, but it's relatively easy to identify episodes that that as long as you do what you've historically done, you will pretty much may have positive NEPRA or positive gain sharing. So how can we help? Well, Persivia can help you both in phase 1 and in phase 2. So we can help you with your application, episode selection, gain sharing model design, care redesign, contracting, and then in the execution stage in care redesign, care management, care coordination, patient engagement, cost and utilization management. So we have the tools and the infrastructure to help you both figure out whether you want to be in the program, and if so, what and how involved you should be, in which episodes you should be selecting, and then once you go in there, providing you the tools to help you manage the process, and in some cases even help you with the actual management of the episodes. Our platform is designed to support all of these processes. We accept data from pretty much any source that you can need data from: EHR data, patient reported, consumer, HL7, diagnostic devices, claims data. We have a decision support engine. We have an integration layer that creates a single longitudinal record, a decision support engine that analyzes all incoming data, and then different modules, everything from an EHR to population analytics, resource utilization, clinical analytics, etc., to help you manage the ongoing episodes. We have significant expertise in integration with all of the major EHRs, both inpatient and outpatient. So we know how to get that data, how to display it, how to make it meaningful. And with that, we come to the end. I'm going to pass it back to Amy now for handling any questions. And thank you for your time, and we look forward to an opportunity to work with you if you decide to participate in any of these programs.
So thank you, Dr. Khan. We'll go ahead and take a couple of questions. We're almost out of time, but we have time for a few. Just as a reminder, if you haven't already put your question into us, please type them into the question box in the GoToMeeting panel. And if we don't get to your question, or you have one after the meeting, please be in touch and we'll answer your question. So one that folks want to know is, will bundled payments become mandatory, Dr. Khan? What are you hearing about that?
So there's sort of mixed, as usual, CMS, is acting like the oracle, and you have to read between the lines and interpret. So Secretary Azar announced a few months ago that they're planning on having 3 mandatory bundles in the near future. They didn't announce a date, but they did announce that. And then a few weeks ago, they announced that there would not be future years, year 4 and 5, as I mentioned earlier in my presentation. So there is sort of an open question right now. Are they going to be de-emphasizing the bundle payment program, or conversely, are they going to have only mandatory bundles? And frankly, I'm afraid only time will tell. But I think from the point of view of any entity that is going to provide healthcare to Medicare, Medicaid beneficiaries, it's a really good idea to get involved in the BPCI advanced program now, while it's voluntary and while the target prices are high, to get the learning and get the processes down and still make some gain sharing. So whatever happens in the program in the future, it's probably a good idea to take advantage of it now.
So another question is, if we apply, does that commit my organization to participate?
So absolutely not. So as we mentioned, there's approximately a 8-month period now where there will be the application process will proceed. So the preliminary application that you file in response to the RFI is not binding. It gets you data that you can then analyze, and then you can choose at that point, after you analyze the data, if you decide that it doesn't make sense for your organization, you can back out, and there's no penalty for that, or at least there wasn't last year. So
a couple questions around participating in multiple programs. So one is, can you participate in both CJR and BPCI Advanced?
Yes, you can, but you would not be able to select the same episodes in BPCI that you have in CJR. So you could pick any of the other episodes, and that would be fine.
And what would you suggest in terms of learning more about it, besides, of course, talking to us? We'd be happy to help anybody who's on the line.
Yeah, so, visit our website. There's some blogs there. You can reach out to us. We'd be happy to provide you information. We have white papers. So there's a ton of information, but the CMS's innovation website also has a significant amount of information available, facts, summary descriptions of the various programs, episode group listings, so on and so forth. So there's a lot of information out there, both on the CMS website, and if you reach out to us, we'd be happy to help you.
Well, thank you. It looks like we've run out of time for today. We appreciate your questions. We appreciate your time today, and hope that we provided some insight into how you can participate in and gain from the bundle payment program as an ACO. And we invite each of you to contact us directly. Our contact information is here to discuss your specific circumstances, and we look forward to partnering with you. Thank you.
Thank you very much.